Hello, I'm Doris Jones from the American University in Cairo, Academy of Liberal Arts, and welcome to the premiere episode of Engaging the Big Questions. As COVID-19 spread across the globe, the Office of the Associate Provost for Research, Innovation, and Creativity issued a call for proposals for its pandemic and post-pandemic research initiative. The initiative clearly stated that COVID-19 was driving research in almost all disciplines. The situation has turned into a global crisis, with many countries, including Egypt, who are resorting to severe measures of lockdowns and curfews. The impact on the global economy is so far beyond the grasp of many. Consequences relating to demographics, socioeconomics, public policies, education, and many other areas of people's lives and practices are bound to change rather dramatically. The sheer scope and urgency of the call resulted in 10 AUC faculty receiving research grants. We are very happy to have with us today several members from one of the research teams whose project is entitled Localizing Health Behavior Communications in the Face of a Global Pandemic, Culture and COVID-19. The team members are Dr. Mona Eimer, who is an associate professor of psychology and the founding chair of the Department of Psychology here at the American University in Cairo. Dr. Eimer is the principal investigator, and she's joined by two members of the research team, and they are Dr. Mary Armstrong Huff, who is a co-investigator, and she is also an assistant professor at the New York University School of Global Public Health, and Ms. Veronica Iskander, who is a sustainable development candidate, and she is also the project coordinator. Welcome to each of you. Dr. Eimer, I would like to begin by asking you to provide our audience with an overview about the project. Could you do that, please?
Sure. Firstly, thank you for inviting us. We're really excited to have a chance to talk to you about the project. The project is an interdisciplinary project that includes members of our team from different backgrounds, including clinical psychology, public health, community psychology, epidemiology, sustainable development, implementation science, and sociology. So the team is a bit large and it has a number of people from different universities. The co-principal investigators are Dr. Jermeen Awad from the University of Texas at Austin and Dr. Chris Dickey from the New York University School of Global Public Health. And this project is an applied research project, which means that the aim is not just to study and understand things, but to take the information and the data that we get and apply it to make recommendations or to influence things or to make some kind of change. And the idea behind the project came really related to what you were saying earlier about how this global pandemic really led to an unprecedented emphasis on research and trying to understand what's going on. And there was also an unprecedented, I think, level of collaboration worldwide in which there is a consistent message or, like a standardization of messages of what we need to do in order to reduce the spread of the virus. In particular, prevention behaviors like wearing the mask, washing your hands. But while things were spreading sort of worldwide in terms of similar messaging and the same messages being duplicated from country to country, from World Health Organization to ministries of health to the local population, one of the things that we were concerned about was, well, what if there are local differences or specific cultural factors that may influence people's behaviors that we need to consider that are getting lost in the translation of the messages that are being spread. And we didn't want to lose sight of that. So we had developed a three-phase research project. The first phase was a survey. The survey was population matched sampling across 12 English-speaking and Arabic-speaking countries. They were collected online by a research firm. And at the end, we had about 4,346 surveys that were valid from the more than 5,000 that we actually received. And from those, a little over 1,000 were from Egypt, from Egyptians or people of Egyptian origin living across 27 governorates in Egypt. And the survey looked at, I mean, it's a pretty large survey. It did look at different factors that could explain or predict prevention behaviors, like wearing the mask and things like that, their beliefs about those kinds of behaviors, and then other kinds of psychological variables that could be related to the experience, like emotional distress, mental health, substance abuse, sense of personal control, and a lot of different other issues. And then the second phase of the project was a training program, a training course that was delivered to frontline workers and policy workers. The training course was a modified version of the NYU training course on behavioral health communication for pandemics. And it was kind of revised to focus more on coronavirus and more on the region. And the results from the survey helped impact or influence some of the content in that course. The course was delivered from September to October over 13 weeks. There were 93 people who participated, mostly, as I said, frontline workers or policymakers. And they came from 28 countries, representing primarily UN agencies like UNICEF, the World Health Organization, as well as ministries of health, ministries of information, private institutions, and also some students attended from different universities. And then the third phase of the project were within that training course, the 93 students divided up into 15 interdisciplinary teams, and those 15 teams developed concepts for projects that could be implemented in their local communities that would be related to the topic of the course. And one of those, for example, was a project aimed at enhancing rates of taking the influenza vaccine here in Egypt. And that project has been rolled out. So from all of these different parts of the project, what we'd like to talk to you about today is really the results from the survey, because there's a lot of really interesting things that we found out that could give us ideas of maybe how we can respond differently if we're trying to change behaviors related to prevention.
Thank you, Dr. Eimer. And as I listen to your description of the three phases, I think for our audience, it's absolutely important to give and to make an acknowledgement, if I would say more clearly, about the magnitude of the collaborative effort that you mentioned, the engagement of 23 or 28 countries, and the number of co-principal investigators who are involved in the process, and the the training aspect. This is quite an enormous project. So I must extend congratulations to you and everyone involved in this project, and certainly what you have accomplished so far. So thank you once again for that wonderful overview. Mrs. Kander, can you provide more information about the countries that were targeted in the survey phase?
Thank you. So basically, the main thing that we need to know is that we targeted 12 countries within the survey, and 7 countries of those 12 were Arabic speaking. And the reason I mention this is because the Arabic speaking countries were more towards the collectivistic scale. And what that means is that the collectivistic countries are more accepting of, or are more targeting towards groups rather than individuals, while the individualistic countries are more targeted towards the individualism. The last thing that I want to mention is that the collectivistic countries were scaled high in the power distance scale. And what that means is that these countries are more accepting of higher authorities and unequal distribution of power within the country, within the community, even within the household.
As we were initially talking about the variables of the critical aspects of the project, I became especially interested in the initial findings regarding the collectivist behaviors, the individualistic behaviors. And certainly you'll have an opportunity to share more about that with the audience. Thank you, Mrs. Kander. I will certainly be coming back to you in a moment. Thank you so very much for that response. So Dr. Armstrong Huff, can you summarize the differences in virus prevention behaviors that were found based on the countries?
Sure. To build off of what Mrs. Kander has just said, I think an important fact that we have to acknowledge when we study the social world is that we as individuals do not exist just entirely independent of one another. Instead, we all live sort of nested in a series of concentric circles. We're nested in our families, in our neighborhoods, in our cities, in our countries. And so when we're thinking about things like differences in COVID prevention behavior, or in the characteristics or beliefs that might contribute to those differences, of course, there are going to be differences between individuals, but there are also going to be differences between our collectives.
And that certainly brings us into yet another critical perspective as well. I must restate a point that I raised earlier, that this project is so multidimensional, that it has so many facets and characteristics about it. I just continue to marvel at what you are able to accomplish, and certainly what you have accomplished and what more you are going to develop. Can you also contrast these results with the results in more individualistic countries?
Yeah, of course. I think that in some ways the power of these survey results is in that contrast. So, like I said, in the more collectivist countries, personal risk perception was not associated with preventative behaviors, but a sense of community, a sense of being embedded in one's community was associated with preventive behaviors like masking. We saw a slightly different pattern in the more individualistic countries like, say, the United States or Canada. Like in the more collectivist countries, in these individualistic countries, personal risk perception was not associated with preventive behaviors once we controlled for other characteristics of individuals or other beliefs of individuals, such as beliefs about the seriousness of the virus. And also, like in collectivist countries, in these individualist settings, the sense of community was still associated with preventive behaviors, but the size of that effect was not as large compared to the collectivist countries. So in other words, in the more collectivist-oriented countries like Egypt, there was a stronger and larger association between an individual's sense of being embedded in the community than there was in these more individualistic settings. So what was it in places like the US or Canada that actually seemed to be associated with prevention behaviors? And it was sense of responsibility. So for example, people who agreed with the statement, we are responsible to prevent the spread of the virus, were more likely to say that they usually masked when they went out in public. And the strength and the size of the association between that, a sense of personal responsibility and prevention behaviors was stronger in these individualistic countries than it was in the collectivist countries. I think that there's sort of an interesting pattern here, and that's that at the individual level, beliefs like I have a right to do what I want with my body, these sort of beliefs that are personal individualistic beliefs. In countries like the US, they predict lower prevention behaviors. So people who make statements like that in our survey are also more likely to say that they don't regularly mask when they go out in public. But we saw a different pattern in the collectivist countries. So although some Egyptians also agreed with the statement, I have a right to do what I want with my body, that kind of individualistic personal belief did not make an Egyptian respondent or a respondent from one of the other Arabic-speaking countries any less likely to wear a mask compared to others. So I think the takeaway here is that people in both more individualistically oriented countries and people in more collectivist countries have some individualistic personal beliefs. There are individuals in these countries that might have more or less individualistic personal beliefs. But the difference is that in those collectivist countries, these personal beliefs don't seem to affect a person's likelihood of engaging in a preventive behavior like wearing a mask. Whereas on the other hand, in the more individualistic countries like the US, holding a personal individualistic belief decreases the likelihood of wearing a mask regularly. So, out of this, we conclude that in collectivist countries, people who have individualistic beliefs are probably less likely to act on those beliefs compared to people who are more in individualistic countries.
I find that the results that you have been able to achieve in a very short period of time, we're talking about just 1 year ago when this project began, and look at the amount of data that you have been able to accumulate again in such a short period. Thank you, Dr. Armstrong Huff. I will certainly be coming back to you again in just a moment. Dr. Eimer, I want to return to you. Can you share with our audience, how will these results be applied?
I think what could be really useful is to look at the particular countries and see what we could do within a particular country that would be better targeted in terms of enhancing the behaviors we want to see, such as the prevention behaviors, or now maybe taking the vaccine. And so I think one of the things that's really striking from the results is that what is already happening to convince people to to engage in these prevention behaviors may not be the most effective way. A lot of the messages you hear on TV or on, through the media, etc., here in Egypt focuses on personal risk perception, or, wear the mask so you don't get sick, or wear the mask so that you and your loved ones don't get sick. And what we know from the research is that that doesn't seem to really be, associated with wearing the mask or not wearing the mask. But things like sense of community and also issues related to community unity, beliefs related to those things tend to be have more of an impact. Now, we can't really change sense of community overnight, something that we already have. Sense of community means that you feel like you're a member of your local, neighborhood or city, that you feel like you have influence and say on what happens, that you feel that the community influences you, and you feel like there's an emotional bonding. So that's something that takes, time to develop, but at least we can work on integrating more sort of messages that relate to the communal responsibility or unity in our messaging to wear the mask, because people may be more likely to engage in these prevention behaviors or take the vaccine or whatever, not because they're worried that they will get sick, but because they feel that they have a responsibility for the community to do those kinds of behaviors. And then there's some other things that came up in the research project as well that kind of relate to Egypt, like some particular religious beliefs and some aspects of religiosity seem to play a little bit of a role in terms of being associated with the prevention behaviors. That doesn't mean that we would, put a lot of religious messaging, but it could be that within religious groups that the messages could be tailored a little bit more, or could endorse those things. Things like, my body is a blessing from God, I have to take care of it, or, the pandemic is a test of our patience, or our faith, a test of our faith. And this was seen across both Christian and Muslim communities. And then, of course, the survey also gave us feedback on the particular subgroups that maybe need to be targeted a little bit more, or who are less likely to engage in those behaviors. Like men were less likely to do the prevention behaviors compared to women. People from lower income areas, they might not have the capacity or the accessibility to things like masks and the ability to physically distance. They may not have the privilege to do that. So those kinds of things may be less likely in those areas. Younger people were less likely to follow the guidelines than older people. And so, we could even look at different governorates and things like that in order to target particular areas. And then maybe that way we can invest the time and effort and financial, contributions to the effort so that we would have bigger impact in a more targeted way.
Absolutely. I think you just touched upon certainly one of the most important aspects of research of this nature is the impact that it will have upon communities. And certainly, as you've already noted, changing social behaviors, basically for the protection and sustainability of communities. I think this is wonderful. Thank you, Dr. Eimer. Let's go back to you, Mrs. Kander. Can you share what are the communication approaches needed to reach people with those messages that Dr. Eimer just mentioned, especially here in Egypt?
What we need to focus on, which was very important actually, was that not only the messages, the type of messages that the different sources portrayed, but also what kind of sources the people used versus what people actually trusted. That is very important within our research and how we implement it later on. So from the data that we collected in the survey, we realized that so the top 5 trusted sources were obviously the WHO, personal accounts from doctors or people who have been infected by the virus, academic scientific journals, government health office, but also and also family members. So these are the top 5 trusted sources. But then when we go to the most used trusted sources, while there are similarities between the trusted versus the most used, we find that there is this discrepancy where social media, out of 21 different sources that we listed out for the participants, turned out to be the 21st source that is least trusted. However, it is the second source that it's used by all participants. So this is very important for us to look at not only the type of messages, but also where we put these messages out for the people.
So I have a question now for both Mrs. Kander and of course for Dr. Eimer. What then are the ideas for how to reach people based on the sources?
Well, I think that it's good to know that people are trusting and using sources like the World Health Organization, as well as the government health offices. And I think that kind of fits with what we were saying earlier about some of the cultures in this part of the world having higher power distance. And so being a little bit more trusting of authority, even though many of us don't believe that that's the case based on the people we talk with, but the research across the 27 governorates showed that that's the case, that people do trust the government health office for information. I think that's a good thing that people are trusting some of those sources, and many of those are the sources that have the biggest sort of clout or impact in delivering the messages nationwide as well. We could do a little bit more work to translate information that is found in the academic journals or in the scientific literature to the general population, maybe through easy like summaries or guidelines or maybe some bullet points or something like that, because it's something that is trusted, but people are not using, presumably because they don't have access to that. So I think those are some of the things that we can think about. Of course, given that people are very attracted and they believe in and they trust and they use personal connections, which again matches sort of that, the collectivistic, culture, that we might want to do more of that. Have videos online that talk about, with people talking about their personal experiences, what they're doing to prevent the virus, or how they're taking the vaccine and how they did not get sick from the vaccine, if that's the case, or the doctors talking about what they've seen with patients and their advice for prevention. And those kinds of like personal accounts may be more influential than the type of messaging that we see more often here, which tends to be sort of like infographics with guidelines or bullet points or instructions that are given to people on TV. And so it seems like there could be a shift in the type of messaging as well that maybe might be a little bit more influential given who people trust. Veronica, what do you think?
Yeah, I think that's exactly what needs to happen in the next step in order to have a more effective result for everyone. But also, while we also change the messaging and use more of the sources that are trusted, we can merge where we use the trusted sources in the most used sources. For example, if we want doctors and people who have been infected by the virus to record videos about their personal accounts and give advice to the public, we can use that and publish it on social media.
Since we're coming to the end of our segment, I would just like to ask each of you, do you have any final take-home messages for everyone?
You know, I think that a lot of us have this assumption that the most important motivation for COVID prevention would be a sense of one's personal risk, right? That we have this idea that when we act to prevent COVID, that we're doing it in order to protect ourselves. But I think that what these survey data in their totality tell us is that people are not motivated so much to protect themselves as they are motivated to protect their families, their loved ones, their communities, right? And so the motivation to act is much more about other people, whether that's to protect those other people, or in some cases to try to be more like those other people. You know, we have examples in the survey of many respondents who themselves reported they didn't think that COVID was that serious, but nonetheless, they were engaging in behaviors intended to stop the spread because others around them were, right? So I think that what this tells us for public health messaging is that community is really important, and that messaging about community is really important. So public health messages that emphasize that preventive behaviors are not just to protect oneself, but also to protect one's community are probably pretty likely to be effective.
I'd like to add something here. One of the really striking aspects of our findings is that it really does challenge some of the existing theories we have about health behavior. So if we look at the health psychology literature, there are models that have been developed that explain why do people behave or act in certain ways in order to prevent illnesses or things like that. And if you look at the components of these models, they tend to be focused on individual level factors like personal sense of risk or the person's like cognitive or mental estimation of the severity or the seriousness of that potential, illness or condition that they might get. A cost benefit analysis about that. Belief in the person's control, over the behavior or the outcome of the illness. So what we call locus of control. And also motivational states, the extent to which the person is motivated to make change, or the extent to which they believe that that behavior really will lead to that positive consequence. So all of these things are happening inside the person in terms of, the way they think or the way they're perceiving or understanding the situation. But our research shows something very different. It shows that most of these variables or these, factors, which we did study in our study, ended up being not as significant or have very little significance in Egypt as well as in other countries as well. And I've never seen a health psychology model that includes sense of community or sort of a relational aspect between the person and their connection with the larger community or society or the collective good as being a important predictor or important factor that affects their behavior. And that's important. Why? Because these models are used to design prevention programs. They're used to design intervention programs. And if we modified these models to incorporate issues like sense of community or some of these more sort of pro-social or relational aspects of our findings, I think the types of interventions that we would develop would be very different.
How can I begin to thank each of you enough for joining me in our premiere episode of Engaging the Big Questions? I am Doris Jones with the American University in Cairo, the Academy of Liberal Arts, and again, we are engaging the big questions. Thank you for joining us.